Welcome, everyone. We're glad that you've joined us today. I begin by acknowledging with gratitude the people who lived and worked in this place where York University is located, the Anishinaabe Nation, the Huron-Wendat, the Haudenosaunee Confederacy, the Métis, and the current treaty holders, the Mississaugas of New Credit First Nation. We acknowledge that when European settlers first came to this land, they entered into a sacred treaty with the indigenous people here, the Two-Row Wampum, an agreement to peaceably share and care for the Great Lakes region. We acknowledge that this treaty and many others have been and continue to be violated by European and Canadian colonial practices that exploit and spoil the land, the water, the air, and all beings that live here. This meeting is virtual, and because of that, York's land acknowledgement may not represent the territory that you are currently on. I ask that you each take the responsibility to acknowledge the traditional territory that you are on and its current treaty holders. This is to remind ourselves that we are all treaty people, and that whatever we do to the land and to others, we do to ourselves. We seek new ways of being in relationship with Indigenous peoples who are our hosts, and with this land where we are guests. Welcome again. My name is Luann Good-Gingrich. I'm the director of the Global Labor Research Center at York University. The GLRC is very pleased to be hosting this launch for two very important and timely books focused on care work and care workers in two distinct contexts, long-term care and home care. The GLRC at York is a vibrant community of scholars and students who engage in interdisciplinary research and collaboration related to work, labor, and livelihoods. And I invite you to check out our website and drop us an email. We'd be glad to connect with you. So a few technical instructions before we begin. Live captioning is available, and you'll see that at the bottom of your Zoom screen. The chat function is not available for audience members, although you might see messages coming from us or through the chat function. If you have a question to ask one of the panelists, you can put your question into the Q&A section, also at the bottom of your Zoom screen. And Leah, who will be our chair for this session, will read the questions and direct them to the panelists. So it's now my pleasure to introduce our chair for this discussion, Professor Leah Vosko, who likely needs no introduction for most of you. Leah is Professor of Political Science and Canada Research Chair in the Political Economy of Gender and Work at York University. Her research in brief focuses on precarious employment, employment standards enforcement, and temporary labor migration. She is also the academic research lead on the SSHRC PG partnership grant called Closing the Enforcement Gap. Leah, that's a very abbreviated introduction to you, but thank you so much for chairing the session today. I turn it over to you to introduce the discussion and our panel of speakers today.
Thanks so much, Luann, for the introduction and the wonderful land acknowledgement. I am absolutely delighted to have the opportunity to chair the launch of two amazing books produced by my wonderful colleague, Cynthia Cranford, and edited by Pat and Hugh Armstrong. Homecare, Fault Lines, Understanding Tensions and Creating Alliances, and the Privatization of Care, the Case of Nursing Homes, with reactions and commentaries from two wonderful labor activists, Mary Gallatley and Anil Nadeau. And before saying a few words about each of these excellent books, I would like to introduce their authors as well as the commentators today. So Cynthia Cranford, to my right, but I'm not sure if she's to your right as well, is Professor of Sociology at the University of Toronto, and she studies inequalities of gender, work, and migration and collective efforts to resist them. She is also co-author of Self-Employed Workers Organize, Law, Policy, and Unions, published by McGill University Press, which, as her acknowledgement suggests, partly inspired some of this wonderful book that we're about to hear about. And Professor Cranford's recent work has been published in many venues, including Critical Sociology, Gender and Society, Gender, Work and Organization, Just Labor, Social Problems, Work, Employment and Society, and many other venues, and volumes. So welcome, Professor Cranford. Pat Armstrong is Distinguished Research Professor in Sociology at York University and a Fellow of the Royal Society of Canada, focusing on women work and the health and social and the health and social services. She's published many books on healthcare, such as washwear and care, clothes and laundry in long-term care, one of my favorites. Troubling Care, Critical Care, The Invisible Women in Healthcare Services, Wasting Away, The Undermining of Canadian healthcare, among many others. Much of this work makes the relationship between paid and unpaid work central to its analysis and is carried out in partnership with community and union organizations. And Professor Armstrong has served as an expert witness in many cases before tribunals and commissions around pay equity and other matters. And she has been the lead on a 10-year interdisciplinary project, Reimagining Long-Term Residential Care, an international study of promising practices that has had many outcomes. And one of them is the book that we'll hear about today. And so she is co-editor of The Privatization of Care, the Case of Nursing Homes. And even though he's not sitting right in front of you, I also want to introduce Hugh Armstrong, who's in the audience, who is a distinguished research professor and professor emeritus of social work and political economy and sociology at Carleton. And Hugh has served as a co-investigator in the project that I just mentioned and on several related projects. And he is also co-editor of The Privatization of Care, the Case of Nursing Homes. So welcome, Hugh, too. Mary Gallatley. Mary is a community legal worker in the Workers' Rights Division at Parkdale Community Legal Services in Toronto. Mary is a clinical instructor in employment law for Parkdale's intensive law program in partnership with Osgoode Hall Law School at York. She has over 25 years of experience in the area of workers' rights and migrant workers' rights. She was one of the co-founders of the amazing Toronto Workers Action Center and also the Caregivers Action Center. For decades now, Mary has conducted community action research with the Workers Action Center and developed interventions into labor policy, producing many reports, public policy reports, and also articles for the Law Commission, among other things. Mary has also been, along with me, the co-lead of Closing the Enforcement Gap, Improving Protections for People in Precarious Jobs, a collaborative initiative that SSHRC has supported, and has very recently served on an expert panel on modernizing the federal labor standards. So welcome, Mary. And then Anil Naidoo is a national representative at the National Union, or the National Union of Public and General Employees, NUPCHI. And he is also on the board of the Canadian Health Coalition and is co-chair of the Canadian Health Professionals Secretariat. Over the last few decades, Anil has been involved with many campaigns in support of strengthening and improving public health care in Canada. He works extensively with workers engaged in paid healthcare work and has lobbied for improvements across the country, most recently in light of the COVID-19 pandemic. So my job today is to serve as chair. However, having recently read both books and being a fan of their authors and editors, I want to start by congratulating Professors Cranford, Armstrong, and Armstrong on their contributions, and their contributors, of course, as well, to analyzing the racialized and gendered conditions of care, which is clearly in crisis in the settings under study. That is nursing homes and domestic care, specifically in-home, old age, and disability support programs. I also want to applaud them for undertaking these works with the aim of forging social change, be it through incremental changes, attempting to provide for flexibility for care recipients and security for workers of the order that Professor Cranford proposes based on her extensive grounded field research with workers, or through centering the provision of care as a public good, that is, as a state responsibility, as advocated in the Armstrong's volume and elsewhere in their work. It is particularly special for me to celebrate these two contributions together today because of just how complementary they are. Each book is a product, in my reading, of anti-racist feminist political economy at its best. Both books are comparative. Both highlight how the work of care is racialized and gendered and shaped profoundly by geographic location, with particular attention to urban settings and to the organization of work in different settings, that is, in the home, in institutional locations, etc. And both underline contradictions and tensions in the provision and receipt of care on account of people's bodily needs and emotional needs, of course. The overarching argument that unifies contributions to the Armstrong's volume is the idea that how we treat the vulnerable resident population in nursing homes, women, many of whom are poor and single, and those who provide care, many of whom are racialized immigrant women, is a crucial indicator of a society's approach to equity and social justice, as well as to care and responsibility. And this contention is not only important, but resonates very strongly with what is happening in the here and now in Ontario, where some of us are located, with marginalized social groups, especially immigrant women, essential workers deemed essential, disproportionately at risk of contracting COVID-19. That the overwhelming majority of those who live in long-term care facilities are older women, many of them with few economic resources and now without partners, if they ever had partners, and that the overwhelming majority of those who provide care are also women in high-income countries, and that a significant proportion of whom are immigrant and racialized is very important. It's also reflective, as contributors to the volume show, of the crisis tendencies in social reproduction under austerity that the Armstrongs have pointed to in other parts of their work as well. The empirical research is extensive for this volume, involving, among other things, 550 interviews, multiple site visits, and of course, it draws on this larger project, examining developments in 6 countries: Norway, Sweden, Germany, the UK, the United States, and Canada, and also probing in-depth developments in 4 provinces of Canada. Very timely. These contributions and indeed the subnational cases that the book canvasses have confronted different challenges, and as the last year I think has shown us, have responded quite differently to the global health pandemic, with Canada and Ontario sadly facing predictable crises, arguably, of a more far-reaching character than perhaps other sites. And equally important are the 4 themes orienting this volume, which validate its arguments about the links between the ways in which vulnerable resident populations in long-term care are treated alongside those who provide them care. That is, the approaches to care and the cultural values they reflect, work organization, something that Professor Cranford delves into deeply in her work, accountability and governance, that is the accountability quantitative or qualitative, democratic or non-democratic, and financing, which is clearly very important around ownership structures and other things that folks have studied. So I really congratulate this team on a wonderful volume, which is both a major contribution to research in the community interest and to teaching. And in fact, as Pat knows, I've used it in one of my classes already. So congratulations. From a different angle, Professor Cranford's book is an in-depth, richly researched and textured study comparing domestic personal support programs in Toronto and Los Angeles, and people that provide care in them and experience care, that provide assistance to adults with physical disabilities and to elderly people across and within class and racial lines, inside and outside of families. Exposing tensions between care recipients' needs for flexibility and care workers' needs for security, profound needs in both instances. The book reveals how worlds of employment and social services can collide with a focus on adults with disabilities and elderly people. And it does so in a manner and to a degree that I don't think is captured in many studies that look at the dynamics between workers and recipients, as they often focus on one or the other. Through interrogating these tensions, the book makes a major contribution to different faces of oppression in a very relational way. That is, it shows how marginalization can affect recipients' quest for flexibility in their care services, and how workers occupying different social locations experience different axes of oppression, in particular along the lines of social relations, of gender, of immigration status, and of class, and as well as race. Devaluation and the lack of recognition that each also affect their pursuit of security. So the normative goal, I think, in Professor Cranford's volume is that of reconciling flexibility with security, as she shows, and how it's challenged by funding structures, by service delivery models, and also, of course, this is interrogated in the Armstrong's volume. And one of the things that Professor Cranford's book does so well is it looks at how these models often approach the kind of dilemmas that workers and caregivers experience as in a very individualistic fashions. That is as tensions between assumedly atomized individuals rather than reflective of institutions, systems, and structures, and the racialized and gendered effects they produce. This individualized model produces. Yet I want to also say that in my reading and my experience of this book, one of the most important contributions methodologically and conceptually that the book makes, and that I think is really unique, and I think it does so by and Cynthia and Pat will perhaps laugh when I say this, but by slicing and lumping, to use the terminology by Miriam Glucksmann, with which at least the three of us are familiar, in a very productive way. That is how it uniquely interrogates what Professor Cranford calls the care recipient worker social location. And so that the set of relations that she looks at, white men and women citizens working for white middle-class citizens, Filipina migrant workers assisting low-income elderly Filipinx immigrant women and men, immigrant men of color assisting white working-class men, and immigrant women of color assisting, I had to write this down, Cynthia, because it's long-winded, white women of various class backgrounds is so very unique and very important methodologically. Like the Armstrong's collection, this book is a tour de force, and in particularly in those ways, in my view, and it contributes especially richly to studies of labor process, of intimate labor, yet it does so in a very unique comparative context to explore what I think all of us would agree are underexplored social relations between social groups of workers and care recipients. So much more could be said. I have many more notes than those that I've referred to, and especially about the incredible empirical research that both these works have involved. But as chair, this isn't my job. I've probably said a little bit too much already, but there's a lot to say about these books. So I guess now is time for the commentators to share their reflections on these works. And I think we're going to begin with Mary Galatney.
Great, thank you. And thanks, I welcome the opportunity to be with such a fabulous panel of people for such an important conversation. I'm going to be taking some of the issues out of Cynthia's book and be focusing on those. Cynthia, you do a really great job of capturing the tensions between care workers and recipients of care. But I'm going to focus on migrant care workers, where that employment relationship is very much mediated through immigration rules. Oh, and to do that, I'm going to use the assistance of a slide deck, which I will just pull up here. Oops. Scrap that. Sorry, folks. How's that? Is that working? Okay. And so Cynthia poses a really important question. Is it possible to build alliances between workers and recipients that's necessary for the flexibility for the care of recipients and also the security for care workers? And so I'm going to address this from the location of having worked with the Caregivers Action Center for basically since we started it in 2007. Just briefly, the Caregivers Action Center is a grassroots organization of current and former migrant care workers that largely come through the federal, basically temporary foreign worker program, as well as workers who have fallen out of status. And so coming from that vantage point and experience, I'm going to share some perspectives from that. And one is kind of in a broad sense, you know, the long-term and the overall goals of migrant care workers is probably the same as many in the care sector. And that is to build a national care strategy that delivers public, universal, accessible, licensed, dignified childcare, elder care, and care for people with disabilities. And again, this is something probably all of us in this virtual room share. But a precondition to such a goal to win has to be to win status for migrant care workers. That is the ability for care workers to come to Canada with their families with permanent status, like so many other quote high-skilled immigrants do. You can't have equality in one sector of in-home care workers where they're working under immigration rules that deny or delay access to permanent residency. It creates huge conditions of exploitation that pulls down wages and working conditions for all care workers, and it divides care workers between those with status and those without. Cynthia rightly concludes that we must grapple with the intersectional inequalities of disability, age, gender, class, race, and immigration status for both care workers and recipients of care. So I'm going to be looking at the in-home care program under the Temporary Foreign Worker Program, and then we'll look at how the CAC, the Caregivers Action Center, is organizing for systemic change, and then bring that back to some of the conclusions of the book. So, you know, we all know that migrant worker or, care workers do the necessary work that enables our society and our economy to function. You know, they feed and care for children so that parents can work. They provide necessary support for the elderly to live out often the last chapter of their lives in their homes. They care for people with disabilities to support independence. You know, this domestic work, child rearing, elder care are all fundamental needs in the labor market and are critical to the well-being of a growing and aging population. Yet migrant care workers do this from a position of precariousness that is created by Canada's immigration and labor laws. We know that largely women have been coming to Canada since the earliest days to provide care for families. And you know, people came and were able to get status and integrate into society. It's only when it became harder and harder to recruit care workers from basically Europe, white Europe, that recruitment started in the Caribbeans of racialized workforces of the former British colonies. That this kind of work began to be mediated through migration, and we saw that more than now over 60 years of experience with temporary labor migration for home care work in Canada has shown us that the ongoing labor market need is consistently accompanied by widespread exploitation and abuse by employers and recruiters. But just for some folks who may not know the basic features of the migrant care worker program, it's called the Living Caregiver Program or Caregiver Pilot Projects. But basically, care workers come in without permanent residency. They come in on work permits that are tied to an employer. An employer has to demonstrate that they cannot get in-care workers resident in Canada. So there's 2 work permits that have to be sought. The worker cannot work for anybody else, any other employer, while under that work permit. The care worker has to get 24 months of service doing that in-home care work. And then once that has hopefully been achieved, they have to perfect their application for permanent residency. And over the past number of years, we've seen the barriers increase where care workers have to have a higher English language level than even citizens are required to have to get their citizenship. And education, they have to have a equivalent of Canadian first year post-secondary, so college, university, which creates huge barriers to workers that have been, working in the country for often 3 or 4 years by the time they get to apply for PR. So those are just some of the kind of main features of the program. I'm going to talk about what working under that kind of a program has meant for people under COVID. And with the Caregivers Action Center, kind of after the first wave, before the second wave, we wanted to get a sense of what was going on. And so we did a study. We surveyed 201 migrant care workers, and largely in Ontario, but also BC, Alberta, from those jurisdictions. And the main thing that care workers have experienced under COVID, it was labor intensification. Half co-workers reported working longer hours, but also more intense work as families started working in the house and children needed support in the house. With that labor intensification came an increase in unpaid wages. So care workers are often paid on a kind of a quote salary basis for 35 or 40 hours, but they're working up 50, 60 hours a week. So there's massive amounts of unpaid wages. We call that wage theft. More than 1 in 3 workers lost their jobs during COVID, during the initial phase of it. And, losing your job is hard at the best of times, but when you're a migrant care worker, it often means you losing your home, as still the majority of in-home care workers are working on a live-in basis. So people had to end up losing their housing. Sorry, I'm trying to get that out of the way. Losing their housing, and it was very difficult to find jobs. For those people that lost their jobs, they had difficulty accessing income support, so EI and CERB, Emergency Recovery Benefit. And that's because with precarious status, when people lose their jobs and their work permit expires, then their social insurance number can expire, and that makes it difficulty to get the basic benefits that they should have been entitled to. Increased employer control over movement. Again, the in-home migrant care work relationship is unlike any other, since you're working in the employer's house. And 1/3 of workers reported the employer controlling the workers' ability to move, to leave the house. And if people were allowed to leave the house, they weren't allowed to take public transit. This created difficulties getting groceries, sending remittances home, accessing healthcare, and those kinds of things. Workers are incredibly worried about delays in getting work permits processed, delays of 3, 6, 9 months. And without an LMIA, there's no work permit, and there's no progress towards getting PR. And, this fear of drives people into ever more exploitative kinds of work conditions. Constant uncertainty about permanent resident status. Many workers report uncertainty about the future. Nearly 60% say they're worried that they're not going to be able to fulfill the 24-month work requirement to apply for permanent residency. And family separation is a huge thing under COVID. The belief that they'll ever be reunited with their families are pushed off into the future as the delays with work permits, job loss, makes people fear the family separation even more. Health crises, access to basic health care. Again, it's dependent on having a full-time job with an active work permit. So for the workers that are pushed out of those jobs and lose their social insurance number becomes expired, they lose access to health care, ability to go visit a doctor, get health care that is necessary. But overall, I mean, it's the cumulative things, all of these things together, family separation, job loss, labor intensification, fears of the future, that create an incredible stress. And yet these same workers don't have access to the kind of mental health care that they need and that others, well, hopefully others have access to. So, you know, with those kinds of experiences, working under that kind of basic framework, much of the work we do at Caregivers Action Center as a grassroots worker-led organization is really focusing on what Cynthia talks about in the last chapter of her book, is an organizing model that engages deeply and continuously with workers to build leadership and participation of care workers that is necessary for systemic change. I'm just checking the time. And so throughout COVID, we have been organizing, doing online, organizing through Zoom. It's interesting because care workers are so isolated in homes. We've actually found that the tools of COVID, whether it's Zoom, WhatsApp, Messenger, Facebook groups, we've been able to actually really expand our capacity and reach and involvement of care workers. And so our membership has grown tremendously, as have participation in the actions we've been doing over the past period of time. So, you know, demonstrations at Mendocino's office, he's the immigration minister, phones apps, postering, letter writing, etc. We've been doing, and I'm just going to share briefly a video that our members put together about our campaign for status and talking about the impacts of COVID.
My employer forced me to stay home for almost 3 months. You cannot go anywhere, you cannot meet your friends. Many people comes and go to the house and not even wearing a mask. I can't refuse, I can't complain because I'm to being scared to lose my job. She will terminate me. I lost my job, and for being lost my job is also losing my family future.
I was working there 19 hours every single day. They only paid me $600 every month. My holiday was start 10 o'clock, and after when I came back home, and they still say, oh, you should work. We are going out, so you should take care of our kids. So yeah, so it's, even the holiday was not holiday.
If you don't have like a good working environment, you tend to like stay with the family just because you have to stay employed.
Because we don't have a permanent residency, that's why our employers taking advantage and we are being abused.
I don't want to lose my job, of course, because I have my family in the Philippines. I'm only the one supporting them. You think of you might lose your income, you will not get paid, or you lose your job because you're ill. I can really straight telling them that I am really sick.
I know that if I get sick, no one can take care of me as well. I'm alone here in Canada.
I didn't know what to do because I was laid off. I didn't know whether I've been fired completely or not. Some of us care workers, we don't have like open work permit. We are stuck with same employer. You also have your family back home to support, so they depend on you.
My daughter is already 18 and 16. And it's really hard because like I miss most of their life already. And I want to provide them with good life, the promise of Canada.
Because of the time difference, it's hard because sometimes they need you, but they cannot reach you because you are working and you cannot even hold your phone. Some employers didn't want you to have the phones with you. Family separation is devastating because it's a mental and physical.
We deserve benefits as caregivers, and we work very hard to support Canadians' family, and we contribute to Canadian society and economy.
We need landed status upon arrival. We need permanent residency so we can take our rights.
We care workers need paid sick days for our own health, for our safety, and for the well-being and safety of the family we were taking care of.
We need to be together. We need the family together. We need the status. Status for all, landed status.
Sorry. Just trying to grab my screen. All right. Yeah, so just in conclusion, by the kind of organizing we were able to do through even during COVID, which is a very difficult time to organize in, we were really able to seize every opportunity, every opening with care workers, with migrant farm workers, to expose the realities of the working conditions and how they are linked to the immigration system, which denies people access. And so just recently, there was just quickly an announcement by Immigration Minister Mendocino to basically regularize the immigration status of about 90,000 migrant workers who have had 1 year work experience. And so a lot of the migrant care workers that I've been talking about will be able to access that, but it's only 90,000. There's 1.6 million people with temporary migrant status in this country. And so the struggle still continues. And so I'll conclude by circling back to Cynthia's question about, is it possible to build alliances between workers and recipients? It's necessary for the kind of flexibility for recipients and security for workers. Now, I have to say two things. First, a necessary precondition is for migrant care workers to have permanent residency status on arrival. That is essential for us to be able to build the kind of alliances necessary. And secondly, as Cynthia concludes, to develop any alliances between recipients and workers across the multiple axes of inequality requires community unionism and the kind of worker-based and worker-led struggles that I've been talking about today. So thanks.
Thanks so much, Mary. I think now we'll turn the floor over to Anil.
Great. Thank you, Leah. Thank you to Luann, Mary, and the Global Research Center for hosting this event and inviting me to participate. Of course, also a deep debt of gratitude is owed to Pat and Hugh and Cynthia and all their collaborators for the vast amount of work that they've done, very timely work. You know, as I was saying just before we started to Pat directly, these things don't come out of thin air. There is decades of work, and the problem is that you know, it takes a crisis like we're in now for these kind of works to get the attention that they deserve. So I'm hoping that you know, my discussion will be more focused on the political moment that we're in and how to turn the work that Cynthia and Pat has done into maybe some action. So I'm speaking on behalf of the National Union of Public and General Employees. We're a union that represents 400,000 workers, many on the front lines of healthcare and many working directly in long-term care and home care. I'm going to be focusing a little bit more on long-term care. It is where the crisis first began. And Mary, through a great presentation, did focus more on the home care issue. I can't say this without talking about all the groups that have done a lot of great advocacy. I'm very humbled to be able to work with many of them daily, including many on the Canadian Health Coalition and many on the Canadian Health Professionals Secretariat that live this day to day. I'm not a worker in the field, but I hope to give some voice to those people today. As Leah said, this book by Pat and Hugh is a tour de force. I would really encourage people to broadly look at it. What they've done is they've broken it down into looking at examples from 6 different countries, and then looking at the key issues and maybe trying to look at a path forward in terms of looking at long-term care as a public good, which I think is fundamental to moving forward. The bottom line is that both long-term care and home care are in crisis. They were in crisis before the pandemic. It was a bit of a slow boil, but that was being virtually ignored, and it now is a complete meltdown. And it's not even the moment that we're looking at, the last year, 14 months. We are in crisis going forward. We just maybe don't recognize it. Partly now it's a mental health crisis. It's a health human resources crisis. And it's also a crisis of, I think of the soul for Canada, honestly, because we've never been in a situation like this. Nothing else that has happened in our country has met the standard of being a full-blown public health crisis failure, honestly. And I do think it's a collective stain, and the only way out of it is through action. As I speak, we are on budget day. Today is budget day. The budget will be in probably around another 2-3 hours. It'll be clear what this federal government has in mind for healthcare and for long-term care and home care. But I think that we can all be, just from the signals, we can probably expect very little, and that's a tragedy, compounding the tragedy of the last 14 months. All of this was predictable and preventable, and I would even suggest that it was criminal. It goes beyond negligence, and we do need to hold our governments and corporations accountable. This may seem like a bit of an extreme position, as the vaccines have begun to have an impact on the death rates. The issues in long-term care particularly may seem to have receded, but we must not allow them to be forgotten. We are still in the midst, as I've said, of the crisis, and it has impacted many and will continue to impact many going forward. And I'm talking about both the residents of the nursing homes as well as the workers. The original sin, if you will, of this is that both these long-term care and home care were not brought under the public health care system. And I know that both Pat and Cynthia are making advocacy in that direction and talking about it as a public good. Right now, what we have is an ad hoc patchwork system that has allowed our most vulnerable to be put at risk, and we must use this moment to change things. Many seniors, their families have been put in this untenable position, and it continues to today. If you look at the news, we have many seniors now are being pushed out of hospitals. In Ontario, I can speak particularly, they've implemented orders that does not need to be consent to move people out of hospitals. They've been termed this derogatory term of bed blockers, alternative levels of care. But there is no solution because the problem has been decades in the making. There is no short-term answer to this because we've allowed our system to become privatized, eroded, and the investments have not been made. So, based on the work of Pat and Cynthia and others and Hugh, none of these deaths should have been a shock. And the failure is that, the first wave, you could say, we were not prepared. We didn't know what we were dealing with. Well, you couldn't say this through the second wave, and you certainly can't say it now through the third wave. And despite the vaccines, which is papering over the crisis in terms of the deaths, the crisis is still there and it is ongoing. You only need to look at the numbers of healthcare workers that have died and where they come from to know that yes, acute care and hospitals get a great deal of attention, and rightly so, but the harm is not restricted to hospitals and intensive care wards, and it is certainly, the deaths are predominantly, honestly, in amongst personal support workers and the people that are outside the hospitals. So again, decades of willful neglect, and I would even say complicity, because a lot of laws have been changed to allow this level of privatization and to allow the corporatization of our long-term care system. And where we stand today is that is continuing. If you look at in Ontario, again, I'll point to some of the laws that have limited liability of these long-term care homes. So instead of holding them to account, we've had governments that have actually stepped in and tried to prop them up, either through, and also through some of the funding that has happened. And we know there's a lot of lobbying going on, and there seems to be no inclination and no political will by our elected representatives to actually deal with what is the core issues that are at stake. Yes, we have had some discussion about national standards in the last throne speech, but we have seen no movement at all in terms of implementing and even a process to get us towards looking at what national standards would look like. So I consider that, until you actually get action, I consider that as a false hope, holding out and extending hope. And even if we do see some funding in this budget, if it goes into a failed and rotten system, then it is not a solution. It is actually, could actually become a way to fuel even more problems down the road, because we have not dealt with what we can see and we have seen is the issue, is that the Canada Health Act, the principles of the Canada Health Act, and there is no public accountability in long-term care, particularly, and even in home care. And this leaves both residents and workers vulnerable. So, I don't know who in their right mind would think that building a system based on profit, not care, will turn out well for seniors or families and for even our country. Yes, we need investment, but we need investment in a public system, one that we can hold accountable, and one that is, we believe at NUPG, under the aegis of the Canada Health Act. Going back to just how terrible this is in terms of collective stain in Canada, we are twice the OECD average in terms of deaths in long-term care and seniors residents. Now that we've bent that curve a little bit with the vaccines, and we're still not out of the woods in terms of the outbreaks, the number of outbreaks that are happening. But certainly the vaccines have meant that we don't see as many residents dying. But that does not mean that we've dealt with the issue, or that residents are even safe in these, and workers are even safe in these facilities. Because if we do know one thing, it's that corporations have a fiduciary responsibility to look at their bottom line. And if their bottom line is impacted by having to provide personal protective equipment or have more staff on, they're going to do everything they can, and they have a responsibility to do everything they can to save money on both those things, in terms of staffing and even providing proper PPE. And no amount of oversight, not that we've had enough, can actually be there 24/7 to protect our workers and our residents. So we do need to structurally change the system. And Canadians are with us on this. There have been polls, Angus Reid did a poll where 2/3 of Canadians favor nationalization of long-term care. We worked with Abacus on a poll and it said that 86% of Canadians favor long-term care facilities be brought into the Canada Health Act. Only 2% oppose this action. Any of you that have done polling or looked at polls, I mean, to have a poll where only 2% of people oppose the question is, almost a statistical anomaly. I've never seen it. So I do think that Canadians are there. Are politicians there? Unfortunately, right now the answer is no. Without what Pat and Cynthia have done is they provided us the foundation, the evidence-based foundation for action. Now it's not up to them to take us to the next level. It's up to all of us to become advocates for our seniors in long-term care, for those people that are trying to stay in their homes under home care, and for the workers that provide those services. I was really struck, Mary, by how compelling and heart-wrenching the stories are in the video that you presented. And I'm really happy that you did that because those are the most marginalized voices in our country. Of course, the residents and the people getting the care are marginalized. But we should not lose sight that there are other victims here as well. It's the people that are struggling and being exploited that we brought into this country. It's predominantly women, it's racialized communities, and it's people that have the least amount of power and are faced with. We've put them in a position of honestly being untenable and being unable to cope. And there will be long-term mental health and physical issues that result from this. And it's on us as a society for allowing this when people like Pat and Hugh and Cynthia have long shown us, what the consequences are and the path forward. I wanted to mention that, where else have we seen, what other country have we seen the military having been called out and step in, and even provinces have to step in to take control of these of long-term care, particularly. There's only 15 pages of the reports that the military produced, but I would suggest that people look at it. It is horrific, in a very understated way, because these are people that are used to being in combat situations. But reading how horrific, people being left, soiled, not getting proper nutrition, not the pressure wounds, ulcers. You can tell that it was horrific, even for people that are, have been trained to be in a kind of battle situation. And that is just not acceptable by any stretch in a country that has the resources of Canada. It's acceptable nowhere. And in a country that, holds ourselves, I think, to what we believe is a higher standard. We have failed. I think that, we've all, have a bit of COVID fatigue at this point, with the number of months that we've been dealing with it. But the issue is that, we had very clear, both even before the pandemic, clear indications of what we needed to do to protect our seniors, and we didn't do it. We left them vulnerable. We left the workers vulnerable. And even in the midst of the pandemic, we still continued to ignore things like having the proper PPE, having the N95 masks available for our workers, of having people single rooms, having making sure that even paid sick leave is there for workers, so they don't have to go in sick, and they can be protect their co-workers, protect the clients, protect the residents. We're not even at the level yet where we're providing that basic minimum of protection, of workplace protection for workers and consequently for the community and for the residents. So, you know, I would say that there is a window, there's a light, because a light has been shone on this sector, and we now, you know, people know what has happened. They know how terrible the situation has become. We also know that politicians are very good at riding out political crises and understanding that that people's attention will turn elsewhere if you can sort of wait long enough. Well, this is one issue we cannot allow that sort of political playbook to be true. We have to continue to go back and remind and demand and press. We know that there will be, you know, coroner's inquests, there will be lawsuits, there will be commissions to look at this and unpack it. But again, I go back to false solutions. Unless we structurally change the way that we provide both home care and long-term care in this country, unless we go to the recommendations of both Cynthia, Pat, and Hugh in their books about looking at it a public good, unless we bring it under the protection of the Canada Health Act and even, you know, force recalcitrant provinces to accept that there needs to be federal oversight. And even our federal government, even though some of the words have been, you know, comforting, the actions have been anything but. There have been no actions taken. And this is just, you know, we are in the midst of the crisis. I know that, you know, people will say, let's wait. Let's wait until the pandemic has been dealt with the vaccines. Well, people have been waiting for decades, people that have been bringing up the issues, and the abuse and neglect and has been ongoing. And I think that we, as Canadians, sometimes we're maybe too, I guess we have too much trust in our systems. We maybe need to make more noise on this issue. I do believe that we do. And I think that this, you know, the books like Pat and Hugh's and Cynthia's provide us that foundation, but the action is on us, as I've said at the beginning, that we, both as advocates for workers, for seniors, we all have to make sure that this is not swept under the rug. I think that, you know, if we look at the failure, I think it's a failure that has impacted the most vulnerable in our society. And we should be judging societies on how they treat the most vulnerable. And in that respect, I think that Canada has failed, and that we have to own our failure in this and take action. So I'll leave it there. And I want to thank both Cynthia and Pat and Hugh for providing us the foundation for others to take forward and to be advocates for this. And again, thanks for inviting me.
Thanks very much, Anil. I think now we're going to hear from the authors, from Pat and Cynthia. And is it Cynthia that's going to go first? Yeah.
Yes. So hello, everyone. Thank you so much for joining us today. And thank you to Luan and the Global Labor Research Center for organizing this event, and Leah for those really nice words about the book, and especially to Mary and Anil for reading the book and commenting and linking it to all of the really great work that you're doing. So what Pat and I thought we would do was to ask each other a few questions. I'm just looking at time, so we'll probably chop the time we had in half, Pat, right? So we have some time for questions from the floor. So I'm going to ask Pat a question now, and then she'll ask me, and we'll go back and forth. Okay, so Pat.
You might want to unmute yourself while Cynthia's talking so we don't have an echo.
Oh, I wondered what that was. Okay, that was an echo. So, I mean, the one version of this question was, you know, we've talked already about that your book is about privatization and the case of nursing homes. And so we've been talking about quite a lot already, sort of what do we learn about privatization from the case of nursing homes? I mean, I think we've talked about already why is it important to analyze nursing homes as a case of privatization, but also like what do we see about privatization through the case of nursing homes? And sort of a secondary question, sort of what are the key tensions? Both of us are interested in these tensions or conflicts, as Leah said, you know, what are the tensions that stem from privatization in long-term residential care or nursing homes?
Somebody should write a book about that. It's that's how long the answer will take. I want to add my collective thank you, and since we want to save time, I won't do it individually, but I appreciate it all enormously. And I should also say that this book is very much a team product. We wanted everybody's name on the outside, but the publishers won't go for that for some reason. To go to this question about privatization and what can we learn from long-term care, what we try to do is to take the notion of privatization to think through the way it is embedded in all of what we do, from what Anil was talking about to what Mary was talking about, and to what many of us have been talking about in other sectors. And we try and unpack privatization. There's only one form of it is about ownership, whether that's the ownership of the place itself or the ownership of the services within it that are contracted out, including management, so that we no longer have clear lines between for-profit and not-for-profit. It's been completely blurred. And as Anil said, they have a responsibility to search for profit. And you do that the traditional way is you pay less and you sell more. Well, they don't even have to sell more, they just pay less. Another form of this privatization is the privatization of managerial strategies, which means that even the homes that are not for profit are being run along the same lines. Pay the least, organize the labor in the ways you can control it. And we have long said that the conditions of work are the conditions of care, and those conditions have deteriorated everywhere, not just in long-term care or not just in healthcare, but in the university, for example, where those who do contract work account for a larger and larger proportion of the labor force. They are much lower paid, but they're also much more likely to be women, racialized, etc. Another form of that privatization is the privatization of costs, shifting of costs to us, not just by lowering the funding, but also by not making those services available through the public sector. So forcing, and we can particularly see this in long-term care, where you're forced to go to private retirement homes or private services, or as Cynthia says in her book, privately pay for home care, or we're even seeing this within long-term care where people hire private companions to fill for the gaps of care. And we're also seeing the privatization of work, again in Cynthia's book as well. You see that the shifting to unpaid care, both by paid workers as well as by relatives and other family members. We see this in both of our sectors for sure. We're also seeing a privatization of decision-making. When it's the corporate sector delivering the service or deciding on the service, there's so much we can't learn and that we can't collectively control, let alone the people who actually live in, work in, and visit in long-term care. And I think finally, it's about the privatization of our heads, that we start to think that it is our responsibility. It isn't a public good. This is the cost to us all. So we have to lower those costs. We have to take this responsibility. And that if we don't care for ourselves or our relatives, then we're failures and we're shirking our responsibility. And so what we're trying to do in the introduction to this book is deconstruct all of that. So we think we have to, and to take up where Anil left off, we have to struggle on all of those fronts. We have to stop thinking that this is our fault and our responsibility and start to think about how we can share it. So So that's how I think privatization is there. And I've addressed some of those tensions, but I want to just raise two. One is the tension between, to some extent, your book and mine, and because one of them is about the private home, and one is about congregate care, right? Which is something I think would be really interesting to take up in the discussion. There's another tension that may not be so obvious, and there are a whole lot of them that we share, no question, across these books, is the tension between safety and risk. What we're seeing this in long-term care, and the focus is on safety and defined in medical care terms, defined very narrowly, and we can't let family into long-term care because it's a risk without recognizing the other risk. And I would say what we also have to think about and put front of stage is what's the risk of privatization and for-profit ownership, as well as all of these other forms. I'll stop there. So I get to ask you something now, Cynthia, do I? I was thinking when I loved reading these books together. I had read yours a long time ago, and then this was saving it up for now so I could read them together. And it's that you'd think that we'd sat in the room together and tried to theoretically figure these out together, and which we have to some extent over the years. But you say in the beginning that I hope that those you interviewed will find that the analysis valid as related to the flexibility, security, tension. So I have two questions in relation to that. Did you start with that frame, or did you come to that frame? That's my first question. And the second was, is your hope realized? I know that's not exactly what we agreed on, but you know.
No, those are great questions. Did I start? So first, did I start with the frame or did I come to it? It's a really good question. I came to it, but I came to it in the first stage of analysis. So I did this work of these 4 case studies over many years. And I also started by interviewing what I considered at the time key informants. So the caseworkers who determine the hours, union activists, disability rights folks, advocates. And so I wanted to understand how flexibility was being used by those various actors. So one of the reasons why I looked at, I used the term flexibility and look at its tension with security. I mean, there's some downsides to this as a labor scholar. It's a neoliberal trope. It's, you know, it's slippery. But I try to do, I think, maybe because I was in so many rooms with you, Pat, when I was thinking about this, is that I also try to deconstruct flexibility. But the first way Leah alluded to a little bit, flexibility for whom, right? Not just flexibility for employers and governments, but flexibility for people receiving the services. There's a whole other discussion about flexibility for workers that I don't get into just because it was a lot to unpack all of the types of flexibility, but also not just that, but also what is the independent living movement? This is a sector of the disability rights movement. What do they mean by flexibility? And often what they mean is also mingled with the neoliberal discourse and the government's effort to do the first form of privatization, of cut back funding, and give funding to private and individualized sources. And that is kind of mixed with what actually the movement means by flexibility, right? And those compromises are made all the time by social movements. And I'm also interested in the people inside these movements and what they think flexibility is, how complicated flexibility is in the daily interaction versus kind of the movement claims as well. And also security, right? What is unique about home care labor, that it's labor in somebody's home, that it's very intermittent, that it's hard to standardize. How do those kinds of claims for security within this kind of very kind of flexible work meet up also with sort of labor movements, either sort of institutionalized inside a union or outside in a more grassroots community-based organizing? claims to push for security. So I was interested in kind of the tension in, the conflict between flexibility and security that we have, because our labor laws are based on kind of the standardized factory model, which many people on this panel and in the room have written about, right? And so there's that mismatch where care work never fit with the regulations of an industrial, unionism or industrial sort of standards. But also I wanted to look at flexibility from the side of the recipients. And first I started interviewing the clients because I wanted to understand them as actors in the employment relationship. And so I started with these questions like, and Leah won't be surprised here, or Mary, like, who is the employer? I mean, I know who the legal employer is, but who are all the de facto employers? And when are the clients also employers? In Mary's case, the migrant workers case, the recipients are the employers, right? And one of my cases is like that too, the direct funding program, the recipients are the employers. And they can get a live-in caregiver if they have enough hours to employ a live-in person. More likely they would be it would be a very middle-class person who would be supplementing what they get from the government with private funds. But in my other cases, the client is not the legal employer, but they do have a lot of de facto employer kind of roles. And so, yeah, I don't know if I've lost the flexibility security, but one of the things I wanted to say I like how you say about deconstructing privatization. One of the things I do with the flexibility security heuristic or analytical kind of framework I'm trying to use is, one is at this labor market level that I alluded to, where, the literature shows, because of our, industrial labor relations regime, that there's that flexibility for employers and even for clients often in the service sector and in care work translates into insecurity for workers. Labor market insecurity, meaning short-term intermittent jobs, multiple jobs, low wages, few benefits, inability to unionize, right? But I also try to look at flexibility in the labor process, right? And so I identify these two flexibility security tensions at this more intimate level, one of which you alluded to, which I call, and we talked about, which I call the tension between knowledge and skill. So the tension between, and this does come out of the data, and that it comes out of the experience of people with disabilities. And this is and so people who've been living long-term with disabilities and know how their body works and know what they can do on a given day and can't do. And so that kind of knowledge of your body and what it needs and how it may change is often in tension at the micro labor process level with the worker's skill, also built up over many years on how to do the work physically, the emotional skill, and the skill at doing housework while you're doing body work at the same time. And so what I try to look at is, it's not just these tensions between dyads, right? They're embedded in, I have these 4 programs I compare, so they're embedded in these different employer level policy and practices, which are situated within the kind of provincial funding model, right? And that, so it matters who's the employer, or when there are employers, how much they intervene, and whether there's a union pushing them to intervene in a certain way. If there's client representation on a board of directors pushing them to intervene another way, or the same, and so that's one tension, knowledge versus skill. And I think that's the one you're alluding to too, which is we come at that in different ways, but there's also a lot of similar things we say about that, I think. And then the other tension, which I think is very similar in both of our work, is this time versus task, right? Like this contracting out to the private sector where there's less time. And so you don't have the time to provide the kinds of flexible care that people really need. So people are doing a lot of unpaid work. There's a lot of wage theft. People are staying over their time. And that's a huge tension that's really accelerated with privatization. Like in one of my cases, the Homecare case, where the privatization is the worst. But you wanted to intervene there on the knowledge versus skill. So
yeah, because I think it raises the question about safety and risk as well. You know, that there can be a risk to the worker if they don't follow what they've been taught, how they've been taught to do it, right?
Mm-hmm, mm-hmm.
Which is if the person who needs care says, you know, no, I want to eat that steak full on,
Mm-hmm.
right? For example,
Yeah.
there is as an example, it's a tension between that I know what I like and what I want to do, and this is what my education has taught me you
Right.
can do, right? And where do you draw that line? But it also, in both of these cases, I think to some extent we're talking about how do you reach a level of autonomy that takes the capacities of both into account, right?
That's right. Yeah. And what are people navigating these tensions as individuals? They are all, in my cases, they're all in private homes, but in the direct funding case, they're more individualized and they don't have a right to unionize and they don't live in, like Mary was talking about, but still that's very different from when you have a unionized environment. You're still working in the home, but you have a manager you feel like you can go to with certain things. And there's a policy that requires negotiation with support, right? And then it's yet different again in the more central, the centralized environment of the long-term care facility, right? Where there is a supervisor that is available or another worker who could help you lift somebody for transfer somebody for, or not.
No, or not.
Which your study shows they're unpaid sort of wives and daughters that are doing it. So maybe I can move and ask you the methods question. Is that, so, you know, as Leah said, and Anil also said, this is a big comparative study and it was a team-based project. So you have 6 countries and I'm just dabbling in, you know, comparative work with this book at a very different kind. But I was really curious to have you reflect on what we learned from comparing these 6 countries. That's a huge question, but also what are the challenges of comparing, you know, 6 countries, like especially within like countries like Canada, where, you know, BC is different from Ontario. And so you take some case studies, right, of it's not just Canada, but you also have the national comparisons, right, that you refer to. So I don't know if you want to reflect a bit on the comparative method. And
well, it's interesting because I was saying this to Hugh. We were talking about this before this occasion, and we actually wouldn't call it a comparative method, even though I know in the book itself we talk about comparison. In part because we think context really matters and makes a fundamental difference. And well, certainly we would argue that looking at other countries, you can learn a great deal. And this particular book out of our project does focus on, does do some comparisons, like the Norway-Sweden one, or where we were trying to get at a particular thing and the factors that contributed to that. And we can certainly learn from other people, but we had this notion of fresh eyes, and one of the methods we used, and a central method to what we were doing, was what we called rapid site switching ethnography, where we would take a team of 12 or 14 people into a home over the course of a week, and we'd start at 7 in the morning and go through till midnight. We work in teams and in shifts. And what was also different about these teams from the way much of the academic research is done is about 3/4 of each of these teams were senior academics who, you know, actually were involved in doing the interview and observations. It was a very collective and reflective, but each of the teams were international and interdisciplinary. And so that wasn't comparative. We were learning together and thinking through how we saw things differently and how we could cross those lines to see things in different kinds of ways. So it wasn't comparative in that sense, even though each team would have people from all of these countries in them, right? So certainly I think you can the comparative method can be very, very effective. But just as I was thinking, oh, we don't have a comparative method, I read comparative all through this book. Yeah, and I think that your book does reveal some very important issues that were comparative. But then when I was reading it, I was thinking, these are big, big cities, right? That you're comparing. What happens when these lessons you're drawing are different if you're moving to where Anil lives? You know, like, is it different if you know, I keep saying this about people saying, you know, Denmark is the nirvana. Well, first of all, Denmark, the population of Denmark is about the same as the GTA. Secondly, they have a very broad and integrated welfare system. Thirdly, they have virtually no homelessness. You know, like, so we felt the same in doing this. Of course, you can learn through what others do. But on the other hand, we were looking for good ideas worth sharing, both about making a difference and what a difference you can make. But we weren't comparing in that sense. So tell us about your comparative method and how you thought, what you were able to do from your perspective that you couldn't have done if you had done the comparisons, because your comparisons are not just between countries, but within Toronto, right?
Mm-hmm. Yeah, I mean, I also have an ambivalent relationship with the comparative method, partly because it's often interpreted, like you said, as kind of what are the factors that led to, you know, let's hold this factor constant and then these factors change and what leads to this given output. And also for me as an ethnographer, although this project is mostly interview based, but I approach it ethnographically in terms of trying to situate the micro within the macro. But for me, like the nation state as a unit of analysis is hard for me I didn't ever want to compare that, but I keep getting asked this question. Every book talk I give, it's like, what do you learn from the US, Canada? I was like, well, I didn't really compare the US and Canada. And so for me, it's also about context, right? It's situating this very unique in LA, this very unique in-home supportive services program within its kind of state level policy regimes, which start at the kind of county level and then go to the California government. And yes, there's the US kind of the fact that in the US, unlike in Canada, we don't even have a federal health act. You know, but then the reason why, so let me set aside the LA at the moment. The three cases, when I did the research, I didn't do them comparatively, I did them sequentially, but then I wrote a comparative book. And when I started to analyze, especially the three cases in Toronto, the analysis was comparative in that I'm looking at like what's the funding model? Like, is it a medical model or a social model? What's the level of funding? Who's the employer? And then what are they unionized? What does the union do? What is the union's kind of strategy, right? And so I ended up writing with a lot of help from friends and editors, a comparative book and I feel like, but then I deliberately also wrote it as case studies and like tried to build the comparison as I go, so I wouldn't lose the context, right? But then you have these three, I have these three case studies in Toronto, which don't even include the entire universe of Toronto. I mean, they don't include the live-in caregiver program, although it could have. I tried very hard not to write about the live-in caregiver program, but as Mary has shown, I was very influenced by that domestic work scholarship, and I circle back around to community unionism, which comes out of that, not only that scholarship, but those social movements that Mary has talked about, right? But I wanted to look at the publicly funded program, but I wanted to look at how it was restructuring, being casualized, privatized, precaritized, right? And so these were case studies that helped me do that. But I actually included the LA case. I mean, I'll say, I mean, most people probably here know I'm from California, and I had studied the LA, the janitors movement in LA and other things. And so I started thinking about that case when I was still there and how it was different from cleaning, from private sector cleaning. But I included the California case in this book as one model of flexibility and security, with a lot of drawbacks because of the context it's in. It's completely means tested. It only applies, therefore, to a small portion of the population. But it is kind of an interesting model. And so if you could take some of the things that were done there and put it in an environment with more, as Anil said, more public support for state-funded care, even though we need to be pushing our governments for that, we could probably do a lot. So I'm also looking at like lessons learned. What if you had these sets of dynamics and they were imposed in this political economy? Or what if you combined these sets? And as I was getting feedback from one of the editors, it was like, which case is the best? And I was like, well, there's no best case. It's certainly not LA. I mean, there's some innovative aspects of it, but like, I don't want to put LA last because I don't want to pretend like it's this kind of best case scenario, but they did do some very interesting things, partly because of a long-term alliance between labor and the disability movement. On the other hand, there's huge problems, right? And so I don't find in any of my cases that it's the panacea, right? So in the conclusion, I actually draw also on the domestic workers movements, other community unionism, to try to think through what flexibility with security would look like. So I like that, and I'm having this conversation now with my grad students about the comparative method, many of them who are doing small N, comparative ethnography. So I'm really interested in this question about method. But yeah, so one more, should we do our last one, or do you have a follow?
Maybe we could, I see Leah suggesting maybe we could go to some questions from other.
Yeah, I think that's a good idea, because the last question was about social change, and I think that Mary and Anil kind of have touched on that for us in a very effective way. So yeah.
I agree.
Okay.
Thank you very much. Very, very rich discussion. All right, so I'm going to take questions from the question and answer box as I have been instructed. And I believe that Louise Bovin has a question to ask first. And in the chat box, Louise talks about the open data of the federal government, and I think that she can say her 2 cents too, but she wishes to inquire into the some of the numbers, pandemic related numbers, and I'll just add my 2 cents, Mary. Maybe you can also talk a little bit. She's asking Mary about this. And Mary, maybe you could also talk a little bit about the limitations of the criteria for this new program. As you know, I work a bit with migrant farm worker activism and scholarship, and while farm workers are listed as people that could apply, it seems quite the stretch to be able to gain access despite many years of coming back and forth to Canada to engage in agricultural work. So I wonder if you could talk a little bit about that as per Louise's question, and if others want to chime in and ask questions, you can do so through the question and answer box, but I'll also monitor the chat function as well for hands. But maybe Louise, do you want to speak before Mary does? Are you out there, Louise? No. Okay. I think, Mary, we will get to Louise's
I don't know if people can speak from the floor in this format.
No, they're not able.
Okay, sorry about that. All right, Louise, I'm monitoring the Q&A.
Oh, okay. So just Louise was asking, trying to get a sense of what were the numbers. And I had mentioned in talking about migrant care workers as temp foreign workers. And that really is more just a general term to kind of gather what has been a very changing program of in-home care by governments. And so like the current name is Home Child Care Provider Pilot, and home support worker pilot. And then 4 years ago, it was called something else. And then it was called something else. So that was just a way to kind of refer in general. But it's generally about 25,000 migrant workers under the program with permits in Ontario. We don't have a sense of how many people have become unregularized or without status. That's always a hard number. And many of those workers do move into, so we do have a number of members who are non-status or working in long-term care facilities, in houses for people with disabilities, etc. And so, you know, undocumented migrant care workers are working in these sectors. And so this new program that just came down, yeah, it's one of those things you push for change and you get a little bit of change, but there's always the devil in the details. And so the announcement about the 90,000, most of those spots are going to go to international students, so 40,000, and then a lesser amount for a whole variety of classifications, including care workers and farm workers. But you have to have a valid work permit. So a lot of people under COVID don't have a valid work permit right now. So, you know, they're kind of out of luck. The other thing is, so it's a valid work permit. And then you also have to have English language level 4. Well, a lot of the migrant farm workers have been coming up from, you know, Mexico, Guatemala, and countries in Latin America. And there's just not the capacity for them to be able to bring their language skills up in the very narrow time window that is available. So, of course, you know, people could live here, work here, and, you know, could contribute and all the rest, but they're just not going to have the time. So there are these barriers that will leave whole sectors. And of course, all the undocumented workers who have been working, doing essential work, won't be covered by the program as well. And yeah, to add anything, yeah.
Thanks so much. Yeah, I think that you're right about the devil in the details, it seems, and really important for looking at these programs. There's another question that I think it's to everybody, and that maybe Pat, Cynthia, Nil, and others will like to respond to, and that's from Ethel Tungohan. I'll read it out, and it is, where did it go? Oh my goodness. That's so long.
I think I might have screwed that up.
It went to answered. It went to answer.
Yeah, I went to answer because I
Ethel,
typed
can
in.
you paste it in again there, Ethel? I know you're out there.
I apologize. I was answering by sending a link to the careeconomy.ca statement that Leah and I have been involved in writing with some other people. But, you know, I'm not technologically the most sophisticated.
Oh, here we go. Here we go. Here she has it again. Good old Ethel here. All right. So Ethel says, do you think this current COVID moment enables us to think more deeply about the importance of care/social reproduction in structuring our economies and societies? In short, do you think this current moment enables us to push through needed changes? What a great forward-looking question from Ethel. Who would like to start and respond here?
I can take a shot at it. Pat, go ahead.
No, go ahead.
Well, I mean, it's a really interesting question, and it gets to the heart of, you know, do we have the political will to make when a problem is exposed to take action? And part of the problem is that we've got a very fragmented kind of federation. Like there is no leadership, honestly, because of the way that people have hidden behind whose responsibility these things are, right? So it goes back to constitutional issues, and everyone will go, well, that's their responsibility, that's their responsibility. We've seen this with First Nations healthcare as well, and the Jordan Principle. And in many ways, when there are sticky situations, it's very easy to claim that, hey, it's shared, or it's not ours, or it's not completely ours. But the question, I guess, becomes, will Canadians allow that to continue this kind of abrogation. And the other part of the problem is that when you get a structural, we've got a fragmented model in long-term care, and Pat will be able to go much more deeply than I can in this, but it's very difficult. There's not one solution to change, right? Because they're all different systems. And you've got municipal, you've got nonprofit, kind of smaller, you've got large corporatized, you've got and it's different in the funding models are different in every jurisdiction. So how do you get change happening? And I do think that it requires we don't have a framework, we don't have a national framework in our minds to say these are the goals, this is what we need to do, and then you can start to move incrementally towards that. The other part is that we're propping up failed models. Like the for-profit model is failed. I mean, you cannot have a system where you rely on public funds, you remove dividends, and even in the midst of a crisis, they're removing vast amounts of money from the system. You cannot have a model that doesn't adhere to basic labor rights and cuts corners on those continuously, and expect so that has to change fundamentally. And there are some political parties that are talking about how to change that, but it will require kind of more of us pushing in the same direction on that particular part. It won't fix the system completely to take out for-profit corporatized long-term care. It won't fix the system completely to have standards, national standards, and in some ways national standards could actually push out some of the smaller groups. I mean, it's kind of a double-edged sword. That's not to say we don't want that, but it's a complex system. But initially, I think the moment is now. If we're ever going to get changed, it has to be now. And so I'll stop because I'm sure Pat has much more to add.
Pat, Cynthia, Mary.
You're muted.
You're muted. Unmute yourself.
Actually, yeah, what I just did was turn myself off in order to answer. That Leah and I, along with Armin Yelnesian, Laurel Ritchie, and Marjorie Cohen, have been working on a statement that we call, that is about an argument for the care economy. And we're arguing to build on what Anil said, that we have to have a more integrated approach and some national leadership and shift our way of thinking, which is what we're arguing, and that we should do so on the basis of a set of principles that we start to develop in that document. So Leah might want to say some more about it. And you can find out about it at thecareeconomy.ca, all in no caps.
Yeah, and I believe Amar Basha has kindly put it in there in the question and answer. But I think we should get Cynthia to jump in here. And also there's a question from Tanya Dasgupta about the makeup of the racial makeup of those who are recipients of care, both in care homes and in individual homes, that maybe Pat and Cynthia want to talk about. I know, Cynthia, in your book, you talk a lot about this, and it's one, as I tried to emphasize it, like in my reading of it, it's one of the most exciting parts of the book, the way you try to look at the relationship in this comparative way, and how important those social relations are. So maybe you want to start there too, but we've heard maybe less from Pat around the makeup of the populations, although I mean I said a few words about it, but you've got lots of data, I know. so Cynthia, do you want to start there?
Sure. Yeah, I think that for Ethel's question, thank you for that question just briefly, because I think others have spoken already to it, but I was heartened by Anil's data that he gave us, the public polling data, which we hear a lot about, that Canadians support public care, but I mean I feel like I've forgotten that recently because there's so much privatization here, and it does really matter who is in power. With the previous government did pass a lot of changes for home-based workers. I mean, Mary and Leah know a lot more about this from the Employment Standards Project, but things that really helped home care workers in particular, making it easier to unionize. This government slashed all of that. So that obviously really matters, but also what I try to do in the book is that really focus on the social movements too, and not just the labor movement and in unions, but the labor movement includes groups like Mary is working with the Caregivers Action Center and the Workers Action Center, and not just their push for all of this really important stuff like obviously status now and paid sick days, but also at this more micro level of leadership development, which these feminist organizations like the Caregivers Action Center and the Workers Action Center, I mean, what I learned from them, 15 years ago now when we did work together was how much work they put into leadership development of women, of immigrant women. And that's very powerful. And the home care and care, long-term care, home care is so diverse. All these different combinations of workers and recipients across class and race and other kinds of abilities that it really, one of the things I try to talk about with this intimate community unionism is that the workers and the clients need to be involved in defining the standards, because the standards are going to be not standardized. That doesn't mean we don't need standards, but we need standards that actually reflect the work. So that was one of the things I wanted to say. But in terms of Tanya, I'm so happy that you're here because you will recognize that this intimate community unionism draws on our work together with you, with Mary, and with Leah and Dina Ladd, and tries to think about it in terms of care work. Just to say that, I'm happy to have you. It's really special for me to do this launch here at York. And so one of my case studies looks at the growing phenomena, not only in California where I look at it, but it's also going here, of kind of co-ethnic care. And so I have kind of a case study within a case study in the Los Angeles case, where there are Filipino immigrant workers who are providing care to elderly Filipino folks. And I've also done this other research in collaboration with Jennifer Chan, with Valerie Damasco, who's I think in the audience, Yang Suk Kim, who's in the audience, looking also at Chinese immigrants in Oakland, California, Korean immigrants in LA, and these co-ethnic care communities. But I also know here from my students that, the recipients also vary too, and also in the long-term care homes, right? There are floors of long-term care homes for, Japanese folks or Korean speaking folks. And so this is a really important issue. And that's another thing when you talk about race and racialization, there's clients' rights to have, people provide them care in their old age, in their language and in line with their culture. And then there's processes of racialization where some white clients have preferences for, white workers. So how do you think about regulating that, right? That's just one way I'm kind of connecting these two questions, which are maybe not so easily connected, but in my case studies, the clients vary as well. So, and when I wrote the book, I tried to pick out, like, in some cases, there's kind of an average client. So in the direct funding case, for example, it's younger people with disabilities who are more likely than the average Torontonian to be white. They have higher levels of education than the general disabled population. So it's a unique group of people. And some of my other case studies, the recipients are also younger, white, mostly people with disabilities, but they're also poor. And so, and then in the home care program, it ranges more between, immigrant communities and white communities. So it's a really great question. And the variation is just kind of endless in that, the client worker combination. Most of the workers are immigrant women of color in a city like the GTA and Los Angeles. And I didn't get to Pat's other part of the question about rural areas, but in the direct funding case, you do have a polarized workforce. It ranges from sort of white Canadian born women who have another full-time permanent job, usually in the care sector, but a lot of them are single mothers and are poor and entered the labor force after their children went to school, ranging from, undocumented workers. So that sector is really varied. So there's just a little bit about the demographics of the clients and the workers. Thanks, Tanya, for that.
if I can, Cynthia answered part of the question about long-term care and the residents in long-term care. That's true if you're in Toronto. And there are lots of actually, you know, Ukrainian homes and Greek homes and Italian homes as well in a city of Toronto. You go at one of the homes we studied in the Ottawa Valley. One of the people we interviewed was the nurse RN in charge who'd just been hired. She said, not only am I the only Black person in this home, I'm the only Black person in town. And and she said, so when I go shopping, people say, oh, you must be the new nurse, because she was alone. Or in Nova Scotia, when we were in Nova Scotia, the entire, not only was everyone white in the home, but they were all related to each other. When one of the residents died, 4 of the workers had compassionate leave because they were all related to the resident. So there are really significant differences in Canada in terms of who's doing the work as well as who's providing the care. And as Cynthia says, if you go to Castleview Witchwood, which is a municipal home in Toronto, there's a Japanese floor, an Italian floor, a Greek floor, but this is another tension, right? So Baycrest, which is has the biggest kosher kitchen in North America, and of course is a Jewish home. But what do you do in terms of admitting people and access to these homes? Should they be able to say, this is a home only for people who are Jewish? Or do you say, as they do, that anyone can come through the system because it is equal? Anyone can apply to go in to that home, which mixes up the population, right? Like the same can be said of the Ukrainian home or the Greek home or the Chinese homes, right? Like, should they or should they not remain specific to their populations? Because right now they are less and less so because you go through the LIN system to get in, and if you put that name on the list, you can get in if it comes up.
I'm just checking the chat, and I have something I might say. All right. So then, oh, okay. Just thank yous to everybody. Very, very interesting.
Maybe Mary wants to tackle Ethel's question if there's not another one.
Yeah, and also I was thinking, Pat, it'd be great if you could talk about community unionism and long-term care.
Mary first.
I mean, it's interesting because we're kind of fighting in so many different places. So around migrant care workers, our orientation really is to link up with other migrant workers who are facing the same challenges from the immigration system. So like farm workers, temp foreign workers, truckers, factory workers, etc. So it's on the basis of status, which, you know, then we have to build power around that demand. But what it doesn't do is start to build those relationships between care workers. And so right now, particularly people are doing elder care, migrant care workers are doing elder care. You know, members will talk about how they'll be, you know, doing all of the care and beyond scope generally. And then the personal support worker comes in, and the power relations between the personal support worker, who gets treated by the case manager and the nurses and all the rest, often kind of takes that out on the care worker in the home, right? And I mean, you totally can see how all of this happening, but so that project, which I identified, is a goal, in home care workers in the long term to build this, national or, cross-country public system which treats recipients and workers well. I think care workers aren't even often in the picture, right? And in part it's because of political priorities, but in part it's also, location of the work, and then how do we, because we still can't unionize, right? There's a prohibition on unionizing care work and farm work. So no answers, but just, yes, thoughts.
If I could just jump in, sorry, Pat, I know I want to ask you to say something about community unionism, but given what Mary has said and Nil's provocation about this is criminal from the outset and pointing to the crisis going forward, and that, this afternoon we're going to have a budget, and the budget is probably going to have a lot of temporary fixes, and I hope some more long-term ones, and everybody's been pointing to the fact that there's been a crisis. When you said that, Anil, I have to say, I thought of the title of a paper of a colleague of ours named Eric Tucker, who wrote a paper that was called When Wage Theft Was a Crime. And of course, a lot of the care workers that Mary works with and that many of us have encountered experience extreme wage theft. And it is criminal. They're supporting people across borders, and it's also got all kinds of gender and racial dynamics, and it's highly exploitative, where people are basically paying for their work permits in lower wages, effectively, or their LMIAs, or like trying to keep their jobs if they're undocumented. So many nuances. I guess I wondered about this sort of thinking about it in sort of criminal terms, or how this affects our campaigns, and thinking about crisis going forward, which is partly why I asked Pat that question about community unionism and long-term care. Like, to the extent that there is unionization, and I know it's limited, I talked to Pat about this a lot, there's more unionization and relatively more unionization in long-term care facilities than in the examples that Cynthia has studied. And partly part of it is the legal situation, and part of it is the different demographic groups that are being cared for. Yeah. I just wonder if you want to comment on that too.
Yeah, I mean, I believe it is criminal. I also believe that we're complicit, like as a society, because we are, the same way we're complicit in buying goods from places we know there are labor rights violations, human rights violations, because we want to keep the costs down. We kind of turn our a blind eye to it. That's the tragedy of having to get to a crisis like this before we turn our attention to something. And the lost opportunity would be that in this crisis we don't get change. But I do think that we're all complicit in it, because partially it's the way we structured we've known about it, and the people on this call and on this session have pointed to it for a long time. But we have allowed it to be downloaded onto the most vulnerable, racial, gender, class. We've allowed that to exist so that we can get a cheaper kind of but it's not sustainable, because we are still funding a fundamentally flawed system that's fragmented and does not have the economies of scale, doesn't have the standards that we expect. And the cost is in terms of the cost to workers, the cost to clients, in terms of the number of ulcerations that you get in private versus public, the numbers of deaths. If you look through the list of deaths, you'll see a lot of people that are visible minorities. And so we have to attack this now. We have to, we can change it. And the one thing I want to say is that, for a long time, it's been that, well, we didn't have the money for it. We couldn't afford this. We can't afford this. That's been put to a lie. I mean, we're willing to spend vast amounts of money to bail out, to prop up, but are we willing to put that capital into fundamental change that's going to be, better? I would even say cheaper. Take the profit out of it and give us all a dignity. Give our the people that need care a dignity that they can that we can all be proud of? Are we willing to put the resources into that? And right now, you know, and we'll know in an hour, I don't see it. And we have to then attack where are the barriers, what's behind this? Is it as Pat has pointed out, that our minds have been colonized, you know, to think a certain way? That may be fundamentally what's going on here, is that we are okay with exploiting the most vulnerable. Are we? I don't think we are. I hope we're not. But I think that the next short while will tell us.
Thanks so much. So do we want a couple last words from the others?
I would like to thank everyone involved in this process, and for those who are have been and hung in there as participants. And I want to pick up on what Anil said, and I think it is, if not now, when?
I love that. I don't want to, I want that to be the last word. So whoever speaks last, can we say that again? But I just want to say that I really appreciate, Anil, you saying that, you know, Pat and I have done this research and now it's everyone's responsibility to kind of take it forward. And I agree, but like I've learned from Pat and Leah and others how to be an activist scholar. And part of what we're kind of committed to is having these kinds of forum where we bring together, where our work is informed by our activism and advocacy and relationships with folks outside of academia, but also that we try to keep having these conversations and build civil society, right? That can push the politicians. So I just want to thank the Global Labor Research Center as a real important, you know, site for these kinds of conversations. So, and to thank Mary and Anil especially for the time and everyone, the time and coming together to talk about these things together.
Thank you.
Thank you. Mary, did you want to say anything? If not now, when?
If not now, when?
Let's make it now.
Yeah, here's to Mary and Anil for such engagement with this work and more broadly. Thanks for wonderful contributions, everyone, to two terrific books, and with a lot of relevance from two great and many great, because there are a lot of collaborators in Pat and Hugh's volume, public intellectuals. Thanks so much, and thanks to Luann and Hauser and the GLRC for hosting.
Thank you, everybody.
Bye.